All right, everyone, I'll bring you back to our first panel discussion. Before we do the panel discussion, I'm going to provide just a brief overview about what approaches should I take, designing for dissemination, implementation, stakeholder engagement, and D&I strategies. The good news is that I'll only be talking for about 10 minutes, and then we're going to open it up for a really lively discussion with our expert panelists that I'll moderate. So the three subtopics that I want to discuss with you over the next 10 minutes are some definitions, approaches, and resources for designing for D&I. Then I'll talk a little bit about meaningful stakeholder engagement, which will really be brought alive by our panelists. And then I'll finish up with talking about how to identify, select, and tailor D&I strategies. So as we've heard earlier today, D&I is still a relatively young and evolving field, as are our definitions. So I have up here a few definitions for what we mean by designing for D&I. And I want to highlight the third definition. So the process of ensuring that evidence-based interventions are developed in ways that match well with our adopters' needs, assets, and timeframes. And designing for D&I might apply to any actionable finding or packaging designing interventions. And so taking this really thoughtful approach to design for D&I is really critical to facilitate effective translation of our research findings into public health practice. And so this was discussed a little bit in by one of the questions earlier, but there's a documented kind of disconnect between practice and research and how practitioners learn about research findings. So this is illustrated by this recent research study showing where researchers believe that clinicians and public health agencies learn about research findings and where agencies actually learn about the findings. And so you can see here that researchers, not surprisingly, we think that public health agencies and practitioners learn about clinical findings from journal articles. But the public health agencies, they report that they actually learn about clinical findings from professional associations and seminars and workshops. So this just kind of underscores the need to really be thoughtful when we're developing and kind of packaging our interventions and where to disseminate them. Also, when designing for D&I, it's really essential to consider what really matters to adopters. And so this is in rank order from most important to kind of least important, what adopters consider important when they're implementing a new innovation or practice. So also not surprisingly, cost is the number one kind of most important consideration. Fourth on the list is actually the research evidence. And for researchers, the research evidence is usually kind of the top priority when designing interventions. So how can we kind of mitigate that research practice gap? So these are some example strategies for designing for D&I by a few key domains. So at the system level, one example is to shift funder priorities and processes. And Dr. Chiang will be talking a little bit about this through the PCORI funding initiatives that have kind of changed a little bit the way that we think about funding priorities. Within the processes domain, a key strategy is early, ongoing, and integrated stakeholder engagement throughout the D&I process. And within the products domain, one strategy is to create dissemination tools like summaries of our research findings in really meaningful and actionable ways. And just kind of building on that a little bit, this was Dr. Glasgow mentioned Dr. Kruder earlier, but some of our public health colleagues have really thought about some innovative ways to disseminate their research findings by looking towards business and marketing models. So I want to just read this quote from Dr. Kruder. Branding and marketing are relevant here at a number of levels. When we think about the universe of evidence-based programs, the ones that are closer to adoption have probably done a better job of thinking through some of the questions that branding and marketing people think through. So understanding audiences, understanding constraints, considering cost, those are classic marketing level strategies. We don't always do that in preparing our program. So some food for thought. To read more about dissemination approaches, we have this article listed in your book. And if you're following along, I should have mentioned this, we're on page 15 of your workbooks. So some of the resources that I'm talking about are listed there. Okay, these next two slides highlight some free D&I tools that can help you as you're designing for D&I. And so this one up here was developed by our Canadian colleagues, and it provides information about how to design for D&I using free fillable PDF versions. So it's not interactive, but you're able to just provide your email access and you get some fillable PDF templates to help you kind of think through your process. And this next resource was developed by the CU Accords D&I group, Russ's group. It's also free and open to the public. It is an interactive tool that provides you with a tailored output report to help you when designing for D&I. Okay, our next subtopic is meaningful stakeholder engagement. So this is one of many graphical representations of stakeholder engagement. And I'm not going to do it justice here in the 30 seconds I'm spending on it, but our panelists will be talking a lot more about the importance of kind of early and integrated stakeholder engagement throughout the D&I process. I want to move into our third topic, and this is about D&I strategies. So what we mean by this is methods or techniques used to enhance the adoption, implementation, sustainment, and scale-up of a program, practice, or policy. There are three main categories or types of D&I strategies. The first is discrete strategies, and these are single actions or processes like reminders or audit and feedback. The second category are multifaceted D&I strategies, and these are combinations of multiple discrete strategies. And then blended D&I strategies, these are multifaceted strategies that have been protocolized, not been branded. So for example, Dr. Glissen's ARC model intervention and Dr. Aaron's LOCI intervention. Byron Powell and colleagues have identified 68 distinct D&I strategies through a very systematic kind of examination of the universe of strategies. And they categorize these into 6 main groups. So these include planning, educating, financing, restructuring, managing quality, and attending to the policy context. And so, for example, in the planning category, some strategies might be assessing readiness or identifying champions. Okay, so we have this great compilation of implementation strategies, 68 to choose from. That's great. How should we select and tailor D&I strategies? The most frequently used model to kind of tailor and decide which strategies to use is Laggett model. So for those of you who maybe aren't familiar, you might know it by, it seemed like a good idea at the time. But we can do better. We can do better at identifying and tailoring our strategies. And so Powell and colleagues have started and will continue to do some great work in trying to make a more systematic process to help tailor and identify the strategies to use. One method to do this is to identify barriers and then link those to relevant D&I strategies. So for example, if an identified barrier is lack of clinician knowledge about a specific evidence-based practice, a relevant D&I strategy might be to develop and conduct interactive education sessions about that practice. Finally, my last slide, I just want to encourage you to name it, define it, and specify it. So This slide here shows 7 domains in which we encourage you to really thoroughly and precisely describe what implementation strategy you are using. And so with that, I want to introduce our panelists. And we have, how this process will go is I will ask each of them one question and allow one other panelist to answer that question, so 2. And then we'll go through the one question per panelist, then we'll open it up to the audience, and then if there's time, we'll do a second round. So we have Dr. Ethan Chiang here, a senior program officer at PCORI. Dr. Elva Arredondo, who is a professor in the School of Public Health at San Diego State University. Dr. Jacqueline Kerr, who is faculty here in the Department of Family Medicine and Public Health, and also an investigator at the Morris Cancer Center. And Dr. Lauren Brookman-Frazee, professor in the Department of Psychiatry here at UCSD, and also an investigator at the Child and Adolescent Services Research Center. Okay. So my first question is for Lauren. So how does the role of the implementation driver shape your design of community partner D&I research? And what I mean by implementation driver, I'm referring to whether the implementation effort is investigator initiated or initiated by the service system or community stakeholders.
Thank you for having me on this panel. And I'm glad that all of you are here today. Can you hear me? Okay. I don't sound very loud to myself. So I've been involved in implementation research that has been both investigator initiated by me, and research that has really been about studying the process of implementation in the context of system-driven implementation of multiple evidence-based practices. And so I think that who the driver is, it does matter, but I'll kind of start by highlighting actually some similarities between these two different contexts of implementation research. So, and I think that what is similar is our desire to characterize and measure using mixed methods the process of implementing one or many interventions. So characterizing that process is similar. Additionally, the measurement constructs, when we think about implementation outcomes, those constructs are similar. I think where there are some differences is in what's the role of the researcher and what's the lens that I play as the researcher in the different types of context of implementation. So I'm involved in leading a few studies that are linked to a system-driven implementation of multiple evidence-based practices in children's mental health in LA County. My role in this research is a neutral observer. So this study was designed to be a neutral observational study. We don't have a horse in that race as far as the marketplace of multiple EBPs that may be available for agencies to select to implement. So I'm able to come at that as a neutral observer and to go in and ask questions that we may get different responses to when I'm coming into it as the intervention developer, the clinical intervention developer. So we've really taken that kind of neutral observer approach and approached this as well when we're talking to different levels of stakeholders, how do you make these practices work in your context? So that's when the system is driving implementation. When I'm initiating implementation, I have more of a horse in this race in the sense that I'm invested. I've been spending many years designing a clinical intervention with the intention of implementation, designed it for end users. And so I do have an investment over many years that my clinical intervention is adopted, implemented, and sustained. Now I still come at it from that question of how do you make this work in your practice? But my lens is a bit different, and I am focused on ensuring that the highest quality intervention or implementation of my intervention is occurring. So I think that that lens is really a key difference in those two contexts of research.
Thank you. I invite another panel member to speak about this topic. If not, then we'll move on to Jacqueline. Question for you is, how do you select D&I models to match your research topic?
Okay, so to give you the perspective of my D&I experience, I went through the TIDA training that's offered by NIH in 2014, and wrote a grant then using the REAIM model in that grant that was funded. And so that project is underway. We actually, in the end, adopted some of the CIFA and the EPIS model to do that. So that's kind of my main project that's underway. And some of these terminologies, this is getting a little intimidating for me, and I'm sitting here as the so-called expert, so it's okay. It's all the process of learning in my mind. I've then actually written 2 other grants that have been successfully funded using 2 different models. So one of them is with my colleague here, Paul Mills, and that was the facilitating the adoption of best practice model, the FAB model, and the other one with this is with colleagues at the Moores Cancer Center, and that was using the diffusion of innovations for service organizations model that Borsika mentioned. So both of those definitely received fundable reviews, but I haven't yet put the models into practice in the research. So how that will actually work out will be interesting to see. And again, a caveat on all those 3 is very much that they weren't reviewed by really true D&I panels. These have been where my D&I knowledge that I have learned came as an extra under a normal study section. So I don't know that, you know, what I had written and how I described them would stand up to a rigorous D&I panel. But essentially, I was lucky when I had gone to my TIDA training that Ross Brownson shared with me this PowerPoint that had the sort of 65 or so original ones. And I just keep going back through that. Those slides, I think that's for me, the visuals of those were so important. And so as I come across these different topics, so the work with Paul is in heart failure clinics, so that's different to the work we're doing in senior centers. And the other work I was doing was in hospitals related to radiation therapy. So the contexts themselves, just when I saw the outline, I was like, that fits. You know, you can look at the constructs under them and realize that what you're doing fits with them. And if you don't get that gut feeling of, if you're forcing it and it doesn't seem to fit, that to me was definitely helpful in my decisioning. But also, and I think, you know, a colleague just asked me, well, something like the CIFA, if you go into the website, how helpful is that? Again, we had a partner, so on our senior center work, Greg Ahrens is a co-investigator. So again, appreciating that you need that additional expertise was really important to us. But I also, you know, I come from a behavior change perspective. There are a lot of behavior change models. To be honest, I've never found any of them helpful. This stuff is helpful. Like when you go through Greg's model and you ask yourself those questions that are under the constructs, we then translated those constructs into qualitative questions or quantitative as well. So example, funding. We ask in our senior centers, has there been any change to funding that would be impacting what we're doing? Or how is funding impacting what you're doing? So we're even looking at city-run senior centers versus foundation-run senior centers, and funding is different. Do they have a grant writer on hand to help with funding, or do they not? So that's what I've really loved about these models, is they're really helpful in guiding. So I've been really happy to come into this field where there seems like something, like the practical side is really there, and it's reassuring.
Thank you. I want to just kind of observe that you've done a really nice job at kind of looking at the breadth of models and choosing kind of a variety that really match the context and constructs of interest that you're kind of focusing on in your research study. So I open it up to the other panelists if you have thoughts about how you go about selecting D&I models for your research kind of area.
So I'll probably answer that with some of my other responses, but for me, it depends on the question of initially, if I'm interested in, say, addressing sustainability, then I would look for models that would be more pertinent to understanding factors that influence sustainability. If I want to focus primarily on implementation and focusing on some of those conceptual frameworks that really tap into those constructs that are determinants into and help explain the process of implementation. So it really depends on where you're at with the questions that you're interested in answering.
No, I just wanted to add before I forget that we've talked about models and frameworks, guiding the selection of what you're going to do, but I think that they should also be useful in communicating what you're planning on doing, and I think that's where things fall out. Having run review panels around dissemination and implementation initiatives, people will say, great, they have a framework, great, they have a model, and people will say, well, what is it doing? How is that going to lead to improvements in health? How is that going to link your activities to your targeted end users? So I think the communication piece needs to really come out when you're talking about models and frameworks and how it's going to lead to impactful use, not just the identification and selection, which in isolation is not particularly useful.
And that's what I think I've tried to do in my grant writing, is sort of take elements and then provide examples of each construct and what it actually means within the intervention we're doing. So yeah, I think that's right. And then, as I say, when that fits, it's a good fit, when you can do that match.
Excellent, thank you. I'll move us on to our next question. Elva, this is for you. So we're going to move into some questions about stakeholder engagement. So Elva, for you, what steps have you taken to engage stakeholders in your research?
Yeah, first, thank you very much for inviting me to be part of the panel. And I'm also, full disclosure, I'm also consider myself a relatively newbie, but I can certainly talk about my experiences in this area. So I consider myself as a researcher who does solution-focused research. So identify the problem and the needs in the community and what I can offer to help address some of these problems. So I consider myself within the continuum of CVPR as a community place, somewhere between community-placed and community-based researcher, because I come in with some ideas and potential solutions, but I also want to hear what the priorities are in the community. So most of my work up to this point has really been, okay, there's a disparity in, let's just say, physical activity. There's a disparity in cancer screening. What can I offer to the community that can help solve some of these issues? So for the most part, initiate communication with community settings, different community organizations, and talk about some of the needs that they have and see if they're in line with what I can offer. So in the work that I've done with faith-based settings, most of my background has been in health behavior change, and my team does include individuals who have expertise in physical activity. So when I approached the churches and talked about the need to increase, to help reduce chronic diseases, which is an important, it's an important disease that needs to be addressed in the community. They agreed, and I offered, well, one way to do this is to implement physical activity programs in the church. And not necessarily a priority for them, but they understand the connections between community engagement. They talked about the importance of bringing the community together and really creating some social cohesion, and that in itself was a priority for the church. So it was not necessarily physical activity that was motivating the stakeholders to collaborate, but really it's more sort of the health promotion and community engagement component. So we we implemented the program, and we were really successful in working collaboratively with our stakeholders. And now that we completed some of the work with them, the question for us is, well, how can we sustain some of the work that we're doing in the community? So that's really what we're grappling with. It's really understanding, well, to what extent do we need to have the organization and the church leadership engaged so that they can, take the ball and run with it after we finish, our roles and responsibilities in the community. So that's what we're doing right now, is just seeing, okay, well, what needs do they have to sustain a program that was successful in the community, and who are they willing to partner with, and what kind of support do they need to continue some of these efforts?
Yeah, I'd love to address this one as well. So we partly started with aging and independent services because we work with older adults, and really a check-in with them. Is the program we're developing something that, if we provide the evidence that you need, because they are also now have more requirements, there's legislation that says they can support programs, but they do have to be evidence-based. And so we said, if we provide this evidence, is this a program that you would think about supporting? So when that answer was yes, then that helped us go forward. So we're working in senior centers, which already do have some physical activity programming, but it's not necessarily evaluated for its impact on health, and also then it's dependent on just a couple of times a week and a specialist instructor. So our program is throughout the week. It involves community engagement as well as physical activity in groups, but also kind of one-to-one counseling so that you keep going with your activity. So we train older adults to run our program. So we have a community advisory board that we take any issues to. We meet quarterly. And the words they use just always astound me. They just say everything better, so that when I'm going back to the community of the senior centers to say something, I'm not using my terms, I'm using their terms, so that really helps. When we transitioned from doing this in retirement communities to senior centers, we realized that a bigger part of what we were doing was going to be to train these peers. So we pilot tested that training. So again, that was making sure we had got that piece right and we're getting the older adults' feedback in how to train them. Then we do a memorandum of understanding with any senior center we're working with. So in that process, we're assessing fit. Is this a good fit for this location? And one of the things that the senior centers see as a benefit of our program, aside from sort of the research we're doing, is we recruit from a wider community than they normally maybe have people coming to the center. So they're gaining new senior center members through our research. So that's a great win-win. We train these peers, but we also set them up to have a network so that they can help each other. So again, I think then they're sort of, that's sort of almost stakeholder to stakeholder. Then we train them in community advocacy. So for example, they would invite the mayor to come and go on a walk for them. Great PR for the mayor starts to be interested in their program. And in the city of Chula Vista, they have taken on sustaining this intervention when our research finishes. So, but that really was, that was nothing to do with us. This was the older adults going out, deciding that was the approach they wanted to take, and proving to the mayor and the city that they were professionals and doing a really good job. So again, nothing on our part. This was them. This was their ability to do that, which I think is so important. And then we talk about sustainment with our groups 6 months into the intervention of a 24-month intervention. So they've had some time to buy into it. And then really they're bringing up with their staff and the senior center director what that sustainment looks like. Are we going to go to the city? Is the foundation that runs the senior center going to do this? And so even though when we do our qualitative interviews every 6 months, we will talk to the director and staff, and they really value what we're doing and they want to be engaged. But when we actually assess, did they come to that sustainment meeting? Did they come to some of the training? They're not necessarily there. So we still have this gap on being able to connect within that system. But in some senior centers, we definitely see that there's total engagement, and we see the difference when that is the case. So it really is very much as both Russ and Borsig said, very multi-level. Our stakeholders come from different levels and the engagement varies.
Great. Well, thanks for illustrating some nice examples of kind of stakeholder engagement throughout the process and different roles that they can provide. I think this is a nice segue into the question for Ethan. So given PCORI's role as a community effectiveness research and D&I funder, what role do you see stakeholders playing as research partners versus implementation partners?
So I'm at the Patient-Centered Outcomes Research Institute, so as you can imagine, patient-centeredness and patient and stakeholder engagement is essential to all the research that we fund. And by stakeholder engagement, we really mean meaningful partnership. Stakeholders and patients shouldn't be participants in your research, but they really need to be integrated into the actual work as decision makers. And we, as Russ said, lip service around patient stakeholder engagement isn't going to cut it for us. It's part of our core mission. We include patients and stakeholders in our research process. One, to ensure patient-centeredness. We want to make sure that the research we're funding is going to answer questions and outcomes that are of interest to patients. But we also want stakeholders involved so that we can make sure the evidence we generate is ultimately going to be useful. And I think a question earlier was around some of the things that can contribute to an implementation gap. And that's one of the direct things you can do to make sure that when you have evidence and you're ready to push it into practice, you sort of brought along all the important stakeholders that are going to help facilitate that process. Around our more recent implementation efforts, moving our PCORI-funded research evidence into practice, we're starting to think about engagement really at two levels. One at the organizational leadership level, but also what kind of engagement do you need at the working level, at the delivery of care, during the clinical encounter. We ask for demonstration of buy-in and commitment from your implementation sites and partners, because that's really where things fall apart if you don't have that. And then more recently, we're thinking about what is the linkage between the policy, leadership, engagement, and engagement at the ground level. Things will often progress in implementation where things are going great here, but they're not communicating. And as a PI or as someone coordinating the research around dissemination and implementation, you know exactly where all the pieces are. But when things start to change, knowing how you can coordinate across that and rapidly adapt in these real-world settings becomes incredibly important. And just to sort of add on to what we were talking about earlier about the models and the frameworks, we recognize that a lot of the people doing the research aren't the best positioned always to disseminate and implement the evidence and move their projects forward. So while the frameworks and models and theories are great, another way that we're starting to think about it are, what is the logic pathway? Describing how you use a model or a framework or a theory to design an implementation project that's going to move you to a place where you can actually start changing practice, changing outcomes. And in stakeholder engagement, if you're trying to get buy-in from the chief nursing operator, the CNO at a hospital, and they're going to say, well, why is this going to work? If you show them CFR, or if you show them any graphics coming from some of these great frameworks, they're going to look at you with blank eyes, and you need to be able to communicate why this particular framework will lead to improvements in their setting and what the value proposition is for this particular approach. So I'll talk more about specific things around engagement later this afternoon, but at a high level, that's sort of how we're thinking about engagement and framing the actual design of your implementation project.
Great, thank you. Anyone else would like to speak about that? Okay, so I'm going to go ahead and open it up to the audience for questions. So anything about designing for D&I, D&I strategies? Yes.
Hi, I want to say thank you to the panel. That was extraordinary. So I want to pick up on something Dr. Chiang mentioned because it had been percolating through my mind the entire time. So Dr. Kerr talked about building in a D&I component into the seniors' work, right? When you were ready to think about training, you built that in to understand what some of the on-the-ground aspects of training might be that would matter for how you implemented the work. So my question is, since 61% of us in the room have not done D&I projects yet, how do we think about structuring our specific aims and our teams and our opportunity for funding? How do we maximize coming through with a streamlined project that is going to fit into many of the funding constraints where you need a team that understands the efficacy aspect, the effectiveness aspect, the actual dissemination aspect, and truly engage stakeholders, because that is going to require formative work before you can even think about getting to some of the other pieces where you're trying to understand relationships. So how do we do that?
Well, I'll give you the easy non-answer first, which is, really building that in before you get started. I think often things get going, and then, you're very excited about your particular research in your own research setting, and you aren't really thinking about what happens when you've got results. And I think the starting point really needs to be sort of that, what happens next if we're successful, and building that in from the start, especially with your choice of stakeholders. If you're successful, who in your setting is going to help you take the next steps with your evidence? Who are your targeted end users? Have you brought on the clinicians that are ultimately going to use your intervention? Have you talked to patients about whether or not they even want this? If you can't make a good case for any of that before you start your research, you're already at a disadvantage. A lot of research now is building stakeholder advisory committees, patient committees, advisory boards, but you have to really think about how you're going to leverage them in a useful way. Focus groups that provide just unidirectional communication are not always the best model for getting feedback. And if you don't have a process to take that feedback and bring it back into your research, then ultimately what was the point of the feedback? And I think those are all early steps that you can take to really think about what your cycle is going to look like when you get to evidence, when you have it. Or even if you have evidence that isn't the positive findings that you wanted, that's extremely important. And Russ mentioned that a little bit earlier. And I think people are often afraid to voice those types of findings, but they're important for implementation and next steps. But anyone else want?
I'll just add a couple things. I completely agree with of this. I mean, I think about, you mentioned the formative steps of your research, and I think about kind of community engagement as needing to happen early and often, and really it's beyond getting letters of support. That is not community engagement, and that doesn't demonstrate that you are engaged in the community in any way. And I think that Ethan used the term bi-directional. I think that can come through in a proposal and is really important. So illustrating what is the community relevant problem that you are going to offer a solution to. Because when we're talking about D&I research, relevance. If you have a solution to something that's not a problem, then it's really kind of worthless, right? And so thinking about, of engaging early to see what are the priorities, what are the pressing problems, what are the policy changes that are going to impact people, and demonstrating early on how those priorities and problems have influenced in a bi-directional way the way that you're thinking about your work, I think is really important. And that just an advisory board that doesn't, that is not bi-directional is not really enough to demonstrate that kind of relevance and how the community context is really informing your work and driving your work.
And we've said, he just added, we've heard about humility several times, and I think that's incredibly important when you're thinking about bringing on non-experts into your project. And no one's going to want to contribute if they don't feel empowered to be a decision maker or contributor. In the same way, as a researcher, I wouldn't want to be involved in a project, spend a lot of time contributing what I think should happen, and they say thank you, and nothing happens.
Yeah. We'll take another question.
Thank you for the great panel. So I just want to continue to build on that point. It seems like a big tension that we're running into is different definitions of success. And I think Dr. Glasgow's presentation set this up, right? Of our definition, oftentimes classically in study sections, is significant difference relative to control, or some variant of that. And then internal validity and all that, and there could be a scientific serviceability, right? What you were just getting into is that the community might have a very different definition of success. Often they do. And so that's just a very hard tension that we're working through. And I know everyone on this panel thinks about this and cares about, let's ground this in the success of what people actually want us to do. But so that's the tension. The question then is, how do we get this through with something like a study section? And I know that's just a very pragmatic question, but it's to me, I really deeply struggle with this, because when I would love to say, I want to try to help you live better, or I want to work with you to kind of help you define what matters for you in a CBPR sort of fashion, and we're going to work forward and achieve that definition of success. But then when we say the study section, we're going to go work with the group, and we're going to help them kind of define what matters most. Then they're going to say, well, you don't know what your study section is, you don't know what your generalizable knowledge is, you don't know what is internal validity, and therefore you're not actually doing science. How do we handle that? And how are we working through that? I know I'm just like throwing a bomb, but I mean, that's the problem. So I'd love to hear your collective thoughts on that.
Thanks, Eric. On studies section, what I see is the groups that come with having already done that formative work. You can't expect to get an R01 and say, we're going to find out what to do. That is still the case. But you do, if you have done formative work and you describe it adequately, you can say, so for example, with us, we train our adults, but they decide, like we give them the components that they need to use, but they decide how they deliver that. And I have seen colleagues on study section criticize that and say, well, that's not standardized. And I'm like, yes, but that's adaptive tailoring. So in some ways I want between Russ's RCT and pragmatic, I want something in between, because, going all the way to pragmatic, I feel there is a step in between. And if we could help define that, then I think reviewers would be more flexible, because they'd say, okay, an adaptive intervention based on, I want these key elements, but how you deliver them is up to you as a team. So, I mean, I think something like that would help. But I really like your question about success as well, outside of study section context, because we have a tracking system to let us know how many participants are attending group walks and things like that, and whether feedback is happening with participants. And essentially, they all feel better, right? They feel great. And that's kind of enough for them. And we're sort of saying, well, actually, you do need another 1,000 steps for that to really impact your health. And they're like, we don't care. We walk together. We do our social thing together. The social is huge in our context. We're okay with that. And so we are still struggling with how do we have the maximum impact on their health, but perhaps in a band that they won't feel, right? They feel that the band that makes them feel good, not necessarily the one that's affecting their cardiovascular biomarkers or something. So we're still struggling with that definition of success, but we're talking to them in our 6 monthly interviews and hearing that, right? So we're at least seeing the discrepancy.
I'll just add a couple things. I really think that the point about the formative stages of research, that has to come before an R01 proposal. And so that early engagement is really critical. As far as measuring success, it's all about relationships. So in partnerships, there may be multiple measures of success. And our community partners understand grant writing, and they understand that, what we need to demonstrate to our funding agencies that this is a rigorous study, that's beneficial to them often if it's designed that way. And typically our partners understand, okay, well, the measures if there's differences in the measures, that we might have multiple measures that are going to define success, and that's really very common in our research, is to have those multiple measures. And so kind of crafting those applications with them, we have found has been very helpful in kind of coming to a place where we agree on how you measure success. The other thing I just want to mention about adaptation is adaptation will happen. whether or not you measure it or not. And so I think that as far as, the community, we often talk about it, that it's messy and it's hard to keep control over multiple variables. And that is the context of your research. So I think from a rigorous research to design, if you don't acknowledge that in an application and have a plan for measuring adaptation or what the changes are going to be, then actually your rigor score can go down, right? Because you're not acknowledging that piece in your application. Because changes will happen. Kind of pragmatism is going to win out, and you can do it in a rigorous way or in the kind of, lack of validity way that we don't want to see in our research.
Oh, did you want to?
I was just going to add to the measurement of success. For the pilot study that informed the trial that we recently completed, the success for the community was empowerment. So we facilitated community audits and park audits, and for the community to go to City Hall and advocate for environmental changes and park improvements. And through that mechanism, we found that those who engaged in that process were actually more likely to engage in more physical activity. So it's finding that what's important to the community and figuring out how that's connected to the health outcome that you're interested in. And I think that in the end, they were also happy to hear that there were increases in physical activity as well, but I think they were more happy at the fact that they could go to City Hall and advocate for a better community for themselves.
I'd say the same with ours. In fact, I think our peer leaders get more satisfaction from that role than they do trying to keep everyone on track with their physical activity goals. So we're glad that we've got that piece as well, because it does provide them more value in their role.
And in terms of measures, not only multiple measures, but appropriate measures, you have to think about short, medium, and long-term success measures too, right? Especially when you're putting these out into the real world. And the case that you're going to make for why this should be integrated and put into place, that measure will be different depending on who you're talking to. And they're very different from a research setting into a real-world setting. So thinking about that as you think about how you're going to try to sell your success measures is important.
Yeah, I'm on study section. I'm critical if basically someone says we're going to do interviews at 24 months. Mm-hmm. It's like, no, throughout, and that was really advice that Greg gave us, do it throughout.
Okay, we have about 10 more minutes left of this session, so. Oh, we have our next question. Russ, go ahead.
Thanks. I've really enjoyed, especially the last few, started by Eric's great question and then your responses there. First, just a tangential comment, because I got so excited. Hear your point about adaptation and transparently reporting on it. It's that one of the things that drives me crazy. People don't, pretending it doesn't exist, doesn't advance science and doing that, but we see that so often, particularly like in multi-site trials. My question relates to something I'm struggling with myself, and that's involving multiple stakeholders with different perspectives. And different perspectives exist depending on where we sit. Particularly, we're trying to do a better job of involving policymakers. And I found that they have quite different perspectives, certainly than does your average citizen or community member, or in my case, like clinicians that we're involved there and stuff. I'm just wondering about your thoughts about that, other than having the world's best facilitator, how to reconcile those perspectives, and then slightly different, but to follow up on Eric's question, maybe for Ethan, about experience with review panels that do involve stakeholders as well as scientists and things like that, and experiences and thoughts and recommendations on that.
Well, I thought inviting the mayor to go on a walk with these older adults, I could have never come up with that idea, but that engaged that city. And then they went to city meetings and saw older adults were not being represented. So in some ways, I think there is a little benefit there to older adults. Nobody wants to ignore them. And so, in fact, leveraging that. So again, for me, when I get out of the way, I think so empowering our leaders to go do it in their own way, but with just that they also come with the kind of professionalism that we bring them in terms of this has got a scientific background. So that's where we help, but then leaving them to go. And our CAB has like multiple types of stakeholders, so they get things from each other, they get used to being in the room with the different voices. I don't think we've got a policymaker there, but we have lots of organizations who do speak to policymakers, so that's where the limit is there.
That's what we've done as well, is that I'm kind of going through a catalog and then our different partnerships as far as who are the members. And certainly we have funders and organizational leaders, so system leaders and organizational leaders, and I'm thinking what we've done in policy is very similar in that they are the ones that are actually interfacing with policymakers. And so this is where we kind of just provide the background support of, I'll get frantic emails. I need a study that shows this. And so then we're, quickly, being able to provide those, the research evidence to support what is, the advocacy effort. So I would say that we tend to provide kind of that responsive technical expertise because they're the ones that are interfacing with policy makers. So it's typically our system leaders and organizational leaders who may be involved in advocacy who are doing that, and then we just provide the support in the background. Oh, do you want to? Oh, sorry.
Greg, I asked for the mic first. Especially for those of you who in the room have published at least like 50 articles on D&I research, but everybody else, please, I wonder if you have seen examples of adaptation of your carefully conceived, model-based, evidence-based interventions that to the extent that you end up with a null trial, how do you deal with that? Have you seen examples of that? Is it my anxiety about this just out of place?
Yeah, so models that have been adapted so that they're not effective, is that, I've actually seen the opposite, and Borshika alluded to one. Earlier, the JJ Trials project funded by NIDA involves 6 centers linking juvenile justice with alcohol drug treatment for adolescents involved in the juvenile justice system. And something like 7 states, 37 sites, and they did a wonderful job of adapting the EPIS implementation framework to fit their project, and then actually use the model not only in the theoretical framing, but to identify measures to track progress through the phases, and to look at both implementation outcomes as well as client outcomes as it goes forward. So there's adaptations to everything, including models, our leadership and organizational change intervention that we're testing. Lauren with Abend Stammer from UC Davis have done a kind of more streamlined version that's being tested. So I think carefully crafted strategies and frameworks are going to be adapted for the specific context. And I think the question about how does this translate to other very different contexts, one of our scale-up strategies, the interagency collaborative team model that we developed here with the child welfare system in San Diego County, is being tested to roll out an adolescent trauma intervention in Sierra Leone, Africa. So these things can and should be adapted, but I think as what Jacqueline was referring to earlier, you have to do a really careful mapping of what aspects of those models need to be adapted in what ways for the local context. And that has to do with also partnering with your communities in a way that's really meaningful for both. So that's my response. I'm going to put a positive spin on it.
I'll just piggyback on that positive spin, not because I'm adapting Greg's intervention, but so we've really carefully measured adaptations actually in that kind of system-driven implementation of multiple evidence-based practices, and then my behavioral intervention for autism and in community mental health settings. And I think we assume that adaptation is a bad thing. And I really, my experience has been that the adaptations for my intervention that people are making, that I choose to actually then standardize that, because that's just better implementation of my intervention when therapists are adapting it to make it work in their context. What we have found when we measured adaptation is that most of the adaptations that therapists make in community mental health are actually pretty consistent. We have used the term from our colleagues, the fidelity consistent or enhancement, and so they are not actually drifting from an intervention, but they show some the way that a provider is engaging in that intervention in a way that is acceptable. So what we found is most adaptations are acceptable, and so acceptable that I end up incorporating those into my standard protocols. So that's typically we've handled it. When we've talked about, we're adapting Greg's loci intervention, we talk about some of those adaptations, and I think you've said, okay, I think we might do some of what you're what you're doing, and so I view it really as a positive process, as long as it kind of adheres to the core principles of the intervention.
Just want to, just really quick, that we actually see adaptation is almost always essential, and it is it's a positive thing. And in fact, if people say they're going to pick their intervention up, drop it into this setting, and they're not proposing to do anything to think about context and the environment, it raises more questions for us. And a lot of the discussions we have are asking our investigators, what are the core components of your intervention that contribute to effectiveness? And if you don't have that as a starting point, it's really hard to make a good case for your adaptation, other than they want it, we think it'll work. You need to have some sort of evidence base for why you're doing this and why you're still going to get the same outcomes, or enough positive outcomes to justify the adaptation.
So we have time for one more question, and I'll send it to the back there. Thank you for waiting.
Yeah, I probably forgot my first question, but I can ask something else by now. This stems from a participant in one of our projects that challenged me about, why did you pick me? How do you know I'm representative of what's out there? I'm in this study and so on. And my naive answer to that was, well, I actually don't know. And then actually, if you weren't voted by a whole lot of people, I can never tell that you were representative enough, or you were the choice to bring forward the participant point of view. And then reflecting upon that on the All of Us program, to the general headquarters, I said, why do you only have participant representatives? You should have non-participant representatives, because that would inform us way more why people are not signing up for this. So unfortunately, that wasn't welcome at that level yet, but I think as we get more experience with it, it probably will. So the question for the experts is, how can you possibly know that the small advisory patient engagement board that you have really represents people who perhaps would benefit much more than the highly engaged participants who are volunteering or spending more hours advising your research?
I agree on that one. I'm very conscious that I am always studying weird volunteers, right? With total respect around the weird, but they're not necessary by simply saying they're willing to take part in research, there's something special, say, about them, but it's not necessarily generalizable. Within our research, we try to interview people that are doing well and who are not doing well, so that we can at least have that perspective. And when we lose people, we try also to do exit interviews. And we do try and ask at recruitment, was there anything specific that, but yeah, I think we are always going to have to realize, and I don't know what percentage that would have, and when you go to the next place, like what's that difference going to be, but we definitely are representing a unique population. Certainly when I feel that, maybe not in the system-led, but if I'm doing a deliverer-led, in some way.
I agree. I think that, that's always a limitation. And so then, I think that the multiple measurements and the mixed methods comes in there because you might be able to reach fewer people with kind of in-depth qualitative, measures. But then if we look at, larger scale quantitative measurements that might be reaching more people, then we can, we can look at to the extent that these are, that we have similarities in the perspectives. And so then it may kind of give us a little bit more confidence in that we are getting more representative perspectives. But I agree, that's always a concern, is to ensure that we have kind of representative perspectives.
I think to the extent you can understand the linkage of your patient and stakeholder partners to the broader communities that they represent in terms of how they interface and how they bring the broader perspective is really important too, because I think you'll find some of the most engaged patient and stakeholder advocates are already doing that, and they have incredible reach on their own, and to the extent that you can leverage that as a part of getting feedback for your particular research will go a long way.
Great. Thank you so much. Oh.
Yeah, I was going to echo some of the stuff. It's fine.
Okay. So thank you so much for your expertise and sharing your experiences with us and for the great questions. Our session right now is complete. We're going to take a 10-minute break, so please join us back here in 10 minutes. Thank you.